Hello, good evening, everyone. It's a great pleasure to welcome you all. We carry the greetings from capital Delhi. Wonderful weather and a great gathering. Good evening, everyone. So it's a pleasure to welcome and invite Dr. Surgeon Raj Purohit, Director with Max Super Specialty Hospital in Medical Oncology at New Delhi. Good evening, sir. We request you with your welcome and introduction on the topic and the proceedings, please. Over to you, sir.
Thank you, Tarunji, and welcome all the esteemed faculty members for this very important discussion on updates on hereditary breast and ovarian cancers. And this one topic is very important because this is one landscape which has been evolving over the last 4 to 5 years, and our patients are getting benefit of the newer drugs which have come, which are all oral drugs and are making a huge impact on the oral survival of such patients. So we'll be discussing starting from molecular oncology to the newer updates, and then to have a moderation of a esteemed panel discussion, and followed by the conclusion. So to begin the batting, we have our own very favorite player. She's a star batsman, like the opener, like Virat Kohli for almost all of us. And then we'll have Dr. Shyam Agrawal and many more superstars for today's evenings. Sir has also logged in. Good evening, sir. Sir, I'm mute पे बस hi बोल रहे हैं. So
hi, good evening. Thanks.
Thank you, sir. Thank you so much, sir. Without wasting much time, I'd like to invite our first speaker, Dr. Aparna Dhar. She is head of molecular oncology at Core Diagnostics, and she will be providing us insights into the optimal molecular diagnostic and then the landscape of this hereditary mutations in breast and ovarian cancer. Over to you, ma'am.
Hi, good evening, everyone. Thank you, Dr. Sachin and organizers for having me here today. So here's hoping that we have a result like the Lord's match that we recently had. So it's always fun going first. But yeah, so I've been given a very difficult task to, chart out the optimal molecular diagnostic algorithm for our patients with breast and ovarian cancer. So I'm going to try and do justice to it. So let's get started. Next slide, please. Right, so before we draw out these algorithms, let's first understand and get a general consensus. Why is molecular profiling so important for our tumors? Because we know that every tumor has different profiles, but that it could also, require unique therapies. We've learned that one target, one drug will eventually lead to resistance. We know one target, one drug does not always inform you of all, go back, of all the more potent targets. One target, one drug does not give you the whole picture. So we've already on to my next slide. So I think in order for us to actually understand what is the ideal molecular diagnostic algorithm in breast cancers, it's very important to understand the tumor's biology. So I'm going to start with breast cancer. Next, please. So our breast cancer patients are classified as per the ER/PR HER2 status, and the triple negative subtype constitutes for around 15% of our patients. The treatment options is chemotherapy. You've got your HR positive disease, which constitutes 70% of our patients, which is hormonal therapy is the mainstay of treatment. And then HER2 positive, where anti-HER2 therapy improves, significantly the prognostic outcome in both early and advanced setting. Next, please. But if you look at it, we've actually moved beyond this intrinsic subtype, such as your, HER2 positive, your luminal A's, your basal-like subtypes, to looking at more genomic drivers, where we've, gone beyond the simple classification. We're looking at alterations in the PI3K pathway. We're looking at DNA damage repair pathway. We're looking at resistance mechanisms in the ER signaling pathway, and we're looking at, growth factor receptors like FGFR1, which could actually potentially allow us to have more targets that can allow us to personalize the treatment strategies in patients with breast cancer. Next, please. Now, the poster child for building a molecular profiling, the algorithm, has always been lung cancer. So if we look at this is a very simplistic way if we look at breast cancer, right? So this algorithm basically is alluding to the fact that you only have 3 biomarkers. You've got ER, PR, HER2. It also assumes that these biomarkers stay static. we know that when a patient's tumor recurs, or when a patient has stage 4, de novo, if there's progression, these biomarkers are not static in about 30% of our patients. So the ER/PR HER2 you could actually have a loss of gain of function. And it's also assumed that there's only one pathway which is dominant, which again, I'm going to show you in a bit, that you really, really need to see different pathways that are activated, in your patient's tumor. Next, please. So again, this is a very simplistic view of patients with metastatic triple-negative breast cancer. Chemotherapy is given, is the option of choice. And you can see the PFS decreases with each line of treatment. Next, please. Now, if we just look at the tumor biology of TNBC patients, we know they're typically associated with the worst prognostic outcome. And as you can see from this heat map over here, that patients with TNBC, it is not as simple as we think it is. Even amongst this group of patients, we see subtypes like luminal AR, you've got the mesenchymal subtype, you've got the basal immune suppressed, basal immune activated. And among each of these subtypes, again, we have different treatment strategies, such as immunotherapy for your basal immune activated subtype, PARP inhibitors for the alterations in the DNA damage repair pathway. You have immunotherapy combinations in basal immune suppressed subtype, and obviously you have your anti-androgen therapy in your luminal AR. So it's not a very simplistic view. Next, please. So taking this into account, this is what I personally feel could be the ideal molecular diagnostic algorithm for our patients with metastatic triple-negative breast cancer. So you can target the defect in the DDR pathway, where we know PARP and platinum has a clear role. You could target the inflamed phenotype, where immunotherapy has a clear role. The AR pathway, if it's positive, we know we have agents, alterations in the PI3K pathway, we have AKT inhibitors. And last but not the least, we've also got those agnostic markers like your NTRK fusions and your RET fusions. Now, I'm very quickly going to walk you through the data based on which I've actually constructed this algorithm. Next, please. So we've got for the Impassion 130 trials for the TNBC patients, which illustrated that the PD-L1 positive cohort had an improvement in the overall survival as it's depicted here in these Kaplan-Meier curves. Next, please. Now, in the case of triple-negative patients with germline BRCA mutation, we've got the EMBRCA and Olympia trials that alluded to the fact that if you have the biomarker and a PARP inhibitor was given, and you can see there's a very nice separation in these Kaplan-Meier curves, for the group of patients who've actually received a PARP inhibitor. Next, please. And now this is very interesting data from a phase 2 trial with TNBC patients, and they received a combination of chemotherapy in the form of paclitaxel and capivasertib, which is a target for the PI3K pathway. It's an AKT inhibitor. And what you can see is that alterations in the tumors actually had a really nice separation of the Kaplan-Meier curves, favoring the patients who were getting the combination versus versus the tumors that did not have an alteration in the pathway. Next, please. Now let's look at the algorithm for the HR positive, HER2 negative subtype. Now, these patients not only have ER/PR as potential biomarkers, but we also need to look at different pathways, such as those that acquire an ESR1 mutation. We know agents such as aromatase inhibitors do not really work well, and you need an agent such as fulvestrant. Again, in the HR positive, there are defects in the DNA damage repair pathway where PARP inhibitor can work, as we've seen in the Olympic trials. We've also looked into the AKT pathway, and then you've got your agnostic markers. Next, please. Now, in the HR positive cohort, I think understanding the tumor biology of the disease is extremely, extremely important. And the reason being, patients do acquire the endocrine resistance. And you can see a very, very nice animation over here, where you see patients who are endocrine resistant, when they're endocrine sensitive, the tumor has a very, very small subclone of ESR1 mutations, and you give them hormonal therapy. And about 18% will acquire an ESR1 mutation. About 13% will have a problem or a defect in the MAP kinase pathway. And around 9% have an acquired mutation in their MYC pathway. And these genomic alterations eventually result in endocrine resistance. Next, please. Now, in some somatic mutations, they differ between early and late or metastatic breast cancers. And ER positive subtype, one of the things that's been very interesting in the last couple of years is actually been the identification and development of tumors that are actually acquiring the ApoBex signatures in high TMB cases. And this could be a potential marker. And I, in particular, am very, I like this particular case study. Next, please, which was presented in ASCO a couple of years ago, where the This patient was initially had an ER-positive breast cancer in 2001, had appropriate treatment for early-stage breast cancer, and eventually had a recurrence in 2010. And then you can see eventually after multiple lines of therapy in 2015, a molecular profiling was done. They saw the ApoBec high signature was there, was found, and she was eventually treated with immunotherapy in the form of pembrolizumab with chemotherapy, and the patient has responded well. So something to look out for. Next, please. You've got your SOLAR-1 trials, which we all are very familiar with, the cohort of patients with a PIK3CA mutation, irrespective if it was picked up in the liquid or the tissue biopsy. They were treated with a combination of fulvestrant with alpelisib. Alpelisib is a PIK3CA inhibitor, and you saw really good responses. Next, please. Now, I've said this earlier, that you can acquire a HER2 mutation, and over time, we've seen this more so in patients which have HR-positive breast cancer. So this was a phase 2 summit trial that took patients with HR-positive HER2 mutant breast cancer and gave them a combination of neratinib and fulvestrant. And do note that these were very heavily pretreated patients. And this combination did result in a good clinical benefit, but it also had a PFS of around 5.4 months. Next, please. So I thought, why not go and confuse the algorithm a little bit more and make it a little bit more personalized for our HR-positive patients that have been treated with aromatase inhibitors and CDK4/6 based on the data I just showed you. Again, this is just my thoughts. Next, please. Right, let's very quickly shift gears and move on to ovarian cancers. And what does this diagnostic algorithm look like? Next, please. Now everybody's talking about the DNA damage repair pathway. You have PARP inhibitors, you have platinum. It obviously has a clear role. Now you could target also the inflamed phenotype where immunotherapy has a role. And interestingly enough, especially in your clear cell, your mucinous, and your endometrioid ovarian cancer, somatic tumor testing for looking for a deficiency in the mismatch repair is highly recommended, especially in your recurrent diseases. So do be on the lookout for this. In addition to that, you've obviously got your you've got your chemotherapy, you've got bevacizumab, and then you also have your agnostic markers like NTRK. Next, please. Right, let's move on and talk about, everyone's favorite PARP inhibitors and its role in ovarian cancer in particular. So what we've learned about the biology of ovarian cancer is that, it's somewhat unique. And although PARP is a ubiquitous function of cellular biology and has lots of different, interactions on normal homeostasis, it does play a very critical role and major role actually in base excision repair. And now, why would, ovarian cancer be kind of unique to the efficacy of a PARP? Well, next, please. The story goes something like this. It's, the disease is actually annotated by a population of cancer cells that have deficiencies in homologous recombination. And there are these two seminal papers that demonstrated that if a cell lacked the ability to repair itself through HRR pathway, that is homologous recombination repair pathway, it was exquisitely, sensitive to PARP inhibition. And what we are saying here is that if we cause a double-stranded break to occur, and there is no mechanism, to fix it, this cancer cell eventually dies. And you can see this in this, this 1,000-fold increase in the sensitivity for these IC50 curves over here. And you're looking at cells that actually lack a BRCA1. And again, this is just preclinical data to support this particular effect. Next, please. So what I've come to learn, now is that one of the mechanisms or a couple of mechanisms by which PARP inhibition works is to do with the process of actually, accentuating the fault in the cancer cell. So the ability of the cell to not repair itself if we induce damage. So if we inhibit, PARP, which can normally fix the defect quite easily by a base excision repair, it's essentially just using the template from the normal strand to fix the gap or the break that was made by the damaging impact. Next, please. So when you actually inhibit PARP or you trap it, then you have the probability that a double-stranded break will happen. Now, this can be fixed by reading the template from the sister chromatid. Now, once it's been established as a read template, and then the remaining strand of the, DNA damage can actually repair itself. And this is what we call homologous recombination repair. And that's what you get, cell survival. If we inhibit PARP, induce a double-stranded break, and it has the ability to repair itself, the cell lives. So PARP inhibition shouldn't really work on cells that have homologous recombination proficiency, which means they're HR proficient. Next, please. However, If they lack HR proficiency, which means they're HR deficient, the cell dies. And that's the kind, that's kind of been the selective, the therapeutic selective window that we've actually been, concentrating, accentuating in ovarian cancers. And again, why ovarian cancers? Next, please. So let's just I absolutely love going back to this pie chart. It's my absolute favorite for the very simple reason. If we just look at the high-grade serous population, it actually gives us very important information. One, BRCA mutations, whether they're a result of germline inheritance or somatic acquired event, is a major component of this population. And if you add them up, they're approximately 20%. Two, there are these other opportunities where we can actually mess up the machinery of homologous recombination. The BRCA1 promoter methylation is certainly one. You've got the RAD51C is another one that's been, that's been proven. And some of these genes that occur as mutations, they don't necessarily induce a HRD state, but the PARP inhibitor works. So many of these factors do reflect that the tumor has an inefficient homologous recombination repair pathway. And in this population, which is nearly 50%, we have the opportunity to treat with PARP inhibitors. Now, I very quickly want to take you to the other side of here, which is another very interesting component, is looking at the HR proficient curve and the cycling E1 amplification. Now, this has been reported in approximately 5 to 15% of high-grade serous cancer, ovarian cancers. But what's unique about it is that it actually appears to be mutually exclusive for all HR deficient pathways. Yes, it is mutually exclusive. There are some reports that may contradict it, but this is what we seem to be seeing. This is what is more generally reported, that it's mutually exclusive. Then we also have the other biomarkers, which we may be able to leverage, especially, deficiencies in the mismatch repair pathway, which I've already spoken about. Next, please. So the key question is, does it really matter if you have a somatic acquired or a germline inherited mutation? And the answer is no. You can see from these Kaplan-Meier curves that the BRCA tumor, the efficacy of the drug is, it has got nothing to do with if it's somatic or germline or it's zygosity. So then the million-dollar question, what do I test first? Do I do germline or do I do somatic? So in my very humble opinion, as we saw from the pie chart earlier, the chances of finding a positive mutation in ovarian cancers is much, much higher in germline versus somatic. And the BEAT, ASCO, NCCN, ESMO, SGO, all of them advocate that at least a bare minimum of germline testing is recommended in ovarian cancer patients, irrespective of family history. In fact, we've got a paper from Dr. Sudeep Gupta, which I think was published maybe a month and a half ago, which showed that 20% of patients who were germline, but a germline BRCA1 mutation did not have a family history, which means it's kind of an insensitive marker in the case of ovarian cancers. And in the Western data, it's close to 50%. So honestly, germline testing upfront, it's also the genetic counselor in me that wants to look out for the rest of the family. So I do recommend germline testing, do NGS and MLPA. MLPA is for large deletion duplications. If that does come negative, then go ahead as a reflex and do somatic testing so you can maybe catch the rest of 5 to 7% of tumors. Now, I do know a lot of doctors do prefer doing somatic first in the hope of catching germline. So you're kind of killing, one bird, two stones, one stone, two birds. What is that? Anyways, you're trying to do both of them simultaneously together so you can, find an answer. But here's the thing, there is discordance between somatic and germline. So if the somatic is negative, you have to go ahead and do germline. You cannot rule out one of the other and say somatic is negative, so there's no germline. All right, next, please. Now, we know tumors that have a deficiency or a mutation in their HRR genes are what we call homologous recombination deficient, HRD. And now this is their mutational signature. Similarly, we can also measure the HRD-ness or the BRCA-ness by actually scoring the genomic instability across the genome of the tumor. Now, there are two ways of doing this. The companion diagnostic for the HRD score, as we like calling it, is the Myriad's MyChoice and the Foundation Medicine. So the Myriad's MyChoice scoring is done by looking at the LOH, which is the loss of heterozygosity, the telomeric allelic imbalance, and large-scale state transitions. These are essentially chromosomal changes that are happening. And if the cumulative score is greater than 42, they say the patient is eligible for a PARP inhibitor. Now, in the case of Foundation Medicine, they only use loss of heterozygosity. And if the score is greater than 16, they say the patient is eligible for a PARP inhibitor. Now, The score essentially is a reflection, what I like to say, of the machinery of what normally governs homologous recombination repair. And if it's broken, it is represented by smoke, but we really can't see the fire because we don't know. The mutational signatures come back negative. So we don't really know where's the fire, but we do find the smoke and we treat it, and and the response is supposed to be pretty okay. Next, please. Now, the assay has a cutoff of a score of around 42, and that's what was used from study 19. That's what even Myriad's My Choice cutoff is. And the MSK group actually, this was a retrospective study where they looked at data from study 19, and they reduced the cutoff from 42 to 33. And what they saw is that when they reduced the score, it actually increased the cohort of patients that could benefit. So I do think that the HRD score is important. Understanding the genomic instability of the tumor for our ovarian cancer patients is extremely important, but I do think that we still need to understand what is the true optimal score so that majority of our patients can benefit from PARP inhibitors. Next, please. I need 2 more minutes. This is the last one. So ovarian, I'm talking about BRCA, I'm talking about PARP inhibitors, platinum therapy. Now, a lot of our patients are heavily pre-treated before they do come on, before they are subjected to these different therapies. So be it pancreatic, prostate, ovarian, breast, you have to be very careful of a phenomenon called BRCA reversion. And what this essentially means is that the BRCA gene, the alterations have the potential to actually restore their reading frame, revert to the wild type sequence, or at least remove the initial deleterious alteration, and it restores at least partial BRCA function. And interestingly enough, BRCA2 is more susceptible to BRCA reversion versus BRCA1. And this is a beautiful case study that demonstrates this concept. And this was a case of a breast cancer patient. She underwent multiple lines of therapy. She obviously progressed. They did molecular profiling. A BRCA mutation was found. She was put on olaparib. She was treated. She had a PFS of around 6 months. She progressed. What they did is they added chemotherapy to the regime, but she continued to progress. At this point, they did a liquid biopsy, and the liquid biopsy actually showed that there was a BRCA reversion, which means she was not going to be sensitive to platinum therapy or PARP inhibitors, and they had to change the regime for her. Next, please. So my key takeaways, go back. My key takeaways are that the tumor biology, especially in breast cancer, is extremely important to help guide therapy. And in the case of, ovarian cancers, BRCA and genes in the HR pathway, I do think are very important, not only from identifying families who are at a potential risk of developing malignancies, but also increasing our cohort of patients that could potentially benefit from therapy. And for heavily pretreated patients, please be very, very careful of BRCA reversion. Next, please. On that note, thank you very much for your patient listening. Thank you.
Thank you, Dr. Aparna, for such wonderful presentation. I think it gives a lot of perspective into how this landscape of HRR is changing the treatment in ovarian cancer, and also the kind of profiles which we need to be really sure in breast cancer. I have one question. One is that almost 10% of the pie chart was of epigenetic pathways. So how do we check for them? Does the Myriad test have those epigenetic pathways, or how do we diagnose that portion of where there is a promoter silencing those areas? How are they addressed?
It's a very good question. I do know that, unfortunately, I'm not aware of a lab in India that's doing it at this very moment, but I do know it is under validation with a lot of labs and us included. But I think be it the Myriad panel, be it Ambry Genetics, be it Foundation Medicine, they all are able to call these mutations out. So the epigenetics part does get resolved over there. They'll actually have a separate column which will say, BRCA methylation present or absent. So it is available. The testing is available in India. It is slightly expensive, but the option does exist. And hopefully labs in a couple of months will be bringing it in-house, and it becomes a little bit more accessible and cost-effective for our patients.
Dr. Shyam, or any of you, any other questions for Dr. Aparna?
So I think I'll take up a few in my talk.
Okay, sir. Thank you, Dr. Aparna, for such wonderful presentation. And now we move to our next speaker, and that is Dr. Shyam Agarwal. And sir, I think, sir, you contribute so much to academics, and it's always so pleasurable to see you across all the firms and listen to the talks which you present. And today, sir will be speaking on one drug, many indications, Lynparza and COPD. Over to you, sir.
Thanks, Sajjan, for this opportunity and invitation. So I think Dr. Aparna has done a wonderful job in trying to address the issue of HRD and BRCA 1 and 2. So which I think needs to be elaborated a little more because I think we all know the indications of Lynparza in ovarian cancer. But I think the nitty-gritty of BRCA1 and HRD, as Dr. Sajjan was asking a question, is sometimes, not clearly understood, and which is what we clinicians must understand. So I think the first few slides are going to be pertaining to BRCA1, 2, and other genes, and HRR genes and HRD, measurement. So can I have the next slide? So I think we are all aware of this. Basically, the incidence epithelial is the most common. And what we are interested when we are looking at PARP inhibitors is high-grade, serous and endometrioid by and large. So the other tumor types, for example, mucinous or clear cell, maybe they don't have the, BRCA1, 2. So I think we all know the clinical thing that majority of these patients would relapse, and it's an unmet need for controlling the cancer and maybe even curing them. Next slide. So, BRCA, as was explained before, is, not uncommon, and HRD is actually common because 50% of patients with ovarian cancer are going to have it. So we are going to, I think we need to, we had a discussion with Dr. Aparna a few days back. So when we are looking at a patient with ovarian cancer, we are looking at that patient, of course, the family is there, but our, immediate focus is to pick up patients who are going to be benefited from this new class of drugs, which are PARP inhibitors. So germline mutations, I think she showed a slide, and I also going to show you a slide, is there in about 14% of epithelial ovarian cancers. And then you have a few more genes, which I'll just show you. And then in addition to germline mutations, there are patients of ovarian cancer who acquire BRCA1, 2, or for that matter, HRD status, positive status, during their lifetime. And that is what we call as somatic BRCA1, 2 mutation or HRD status. So we are interested in BRCA1, 2 and HRD status. Whether it is germline or somatic is secondary, because all such patients are supposed to derive benefit from drugs like olaparib. Next slide. So I think this has already been shown that, PARP inhibitors, give you that synthetic lethality. Next slide. So that is the, just 1 second. You just have to excuse me. I think the power is going to go up. Just give me 1 second. So that is where these drugs are going to be used. For example, maintenance in newly diagnosed high-grade serous carcinoma, a relapse in platinum-sensitive setting, and third line. So, but where should we do the test? When we should do the test, I think that is an important issue. Next slide. So this is what I think Dr. Aparna was also referring to. So currently we are focusing on BRCA1 and BRCA2. But then HRR genes, for example, RAD51C, PALB2, and CHEK1. So these are important contributors to the development of HRD. And that is where, we are looking at HRR genes also at this point in time. I think Dr. Aparna showed you that slide, that HR genes, if there is a mutation, well, they are likely to benefit. So that benefit is derived from the development of HRD status. Next slide. So this is, as you see here, that BRCA1 and 2 contribute majorly to the occurrence of HRD status. So these are 50% are HRD positive, and you see 7% the non-BRCA HR genes, which is what I just showed you, and they are mentioned here as well. CHEK1, RAD51, PALB2, and so on. Well, they also can contribute to the development of HRD. And Dr. Sajjan was asking the question, which I'll just show you in the next slide, I guess. In the other causes of HRD are those epigenetic. So you're not looking for epigenetic directly, but those epigenetic changes, they manifest in the form of HRD, which I'll just show you how you test that. Next slide. So these are, promoter methylation. You see RAD51, CHEK12, CHEK1 and 2, the Fanconi gene, RAD gene, core RAD gene mutations, etc., MC amplification, and P10 homozygous. So these abnormalities in the tumor cell can result in HR deficiency, and these patients are to be treated with olaparib-like drugs. You see here, 8 plus 14%, and another 6% will have somatic mutations in BRCA1 and BRCA2. So the question is, currently what we are doing is BRCA2, somatic and germline, BRCA1 and BRCA1, germline and somatic. So we are just getting the results of these 25% or so cases, and the HRD we are not able to perform just because of the cost factor. So how do you look for the HRD? Next slide. Let's go. So it is unclear which mutations in the other than the BRCA1, 2 are responsible for HRD. So although we showed you the slides for RAD1, 51 and CHEK1, etc., but there is no clarity, as this slide says. It is not clear which mutations in HR pathway. BRCA1, 2, sure, there's no discussion. Mutation in other HR genes are too rare to account for all HRD, and we would miss HRD due to promoter methylation. So this is a very important slide. So what you are looking at is the scars which are caused by changes in promoter methylation or by other gene silencing, etc. Next slide. So this is how we are looking at. So BRCA1, 2, other HR gene mutations, promoter methylation, and certain other DNA damaging repair genes, DDR genes as they are called, which are another 50 or 55 or so at this point of time, which we understand. They result in loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions. So there is a scoring given to this, and as Dr. Aparna was telling you, if the score for all this is more than 42, and that is the algorithm which Myriad has, and they are privy to that, and they have a patent on that. So you look for HRD, which is happening as a result of these mutations in BRCA1, 2, HR gene, promoter methylation, and things which we don't understand. So we are looking at the scars, and 25% is, as I said, BRCA1, 2. The rest 25% is here, but then we don't know whether HR gene mutation is which HR gene mutation is responsible for HRD. We don't know, and that is why we are focusing on HRD. So HRD becomes so very important at this point in time to include those extra 25% of patients to be treated with a drug like olaparib. Next slide. So I think to assess HRD, either we look at these gene mutations like BRCA, and these mutations we are not sure, as I've shown you, but what is more important is the output to assess the downstream characteristics, which include, as I showed you, LOH, telomere allelic imbalance, and SIT, which is called as genomic instability. Next slide. So I think once you have understood this, well, then the life becomes fairly easy. Then it is just a question of going through the trials and figuring out the benefit from a drug like olaparib. So I think I'll not go into this slide, already shown before. Next slide. Yeah, so I think for my choice, from the Myriad, you see, they look at the tumor BRCA status, and they look for these three things and tell you that the patient has HRD or not. And both Prima and Paola 1 studies determine HR status using myriad MyChoice companion diagnostic test. So I think once you understand this, and the score needs to be more than 42. So either tumor BRCA and or genomic instability figured out by these 3 testing. They're not difficult tests. They look like very, fancy terms or difficult terms. But in the lab, I believe Dr. Aparna and so many others can do this. But then the algorithm to come at 42 and the validation is not easy. Next slide. So this is a slide to showcase where is the clinical utility in the first line maintenance and in platinum sensitive relapse disease. So BRCA mutations in the germline on tumor, you see good clinical utility in both the settings. Somatic BRCA, again, good. But when you come to non-BRCA HRR genes like PALB2, RAD51, etc., so there is no evidence in maintenance, and there is marginal benefit in the clinical utility with PARP inhibitors in sensitive to platinum relapse disease. The HR genomic scar assays, GIS, yes, which includes LOH and 2 more. But if you look at LOH alone, there is no evidence in the maintenance. There is good evidence in the clinical utility of the platinum sensitive disease. So I think Dr. Aparna said that the foundation people are looking at LOH only. So you can't use that thing in the maintenance, but maybe you can think of using it in the platinum sensitive situation in a relapse setting. So these are important concepts which we must know about the BRCA, HRD, etc. Next slide. So I think this is now it's easy to understand who are benefiting, why they are benefiting. Next slide. So these are olaparib maintenance treatment has been investigated in newly diagnosed ovarian cancer in 2 phase 3 studies. So one is the newly diagnosed ovarian cancer, any surgical outcome, BRCA mutants. So these patients were BRCA mutants, and solo 1 was done after surgery and chemotherapy for olaparib maintenance. And the other study is the Paola 1, where all groups were included, whether they had BRCA mutation or no tumor BRCA, HRD positive, HRD negative, and they had bevacizumab in addition. So I think these are 2 important maintenance studies for olaparib. Next slide. So next slide. So I think next slide. So they gave the treatment for 2 years with olaparib, following treatment with surgery in 3 and 4 stage high-grade and endometrioid ovarian epithelial cancer, peritoneal cancer, and fallopian tube cancer. So I think the PFS was studied and the PFS2 was studied. So 2:1 randomization. Next slide. So I think these are to show that these patients were fairly balanced. 73% patients had BRCA1 and the rest had BRCA2. And high-grade serous was seen in 95% of the cases. Stage 3 and 4 cases were there. Next slide. Majority were ovarian cancer. So I think we all know the curves very well for Solo 1 trial in favor of olaparib, where you see 56 months versus 13.8 months for placebo, with a very robust hazard ratio. Next slide. At a 5-year follow-up nearly. I think all of us have started using olaparib, and GI disturbances, oral ulcers, fatigue, anemia are common side effects, which I think we need to understand and maybe, reduce the dose depending upon the tolerance. Next slide. So again, this is a trial for, you can see here, between bevacizumab and olaparib versus bevacizumab alone, and patients stage 3 and 4, and irrespective of BRCA status. Next slide. So I think again, these 2 arms are fairly well balanced. Can we go to the next slide? So this is to showcase that disease progression was seen much more in the bevacizumab arm, and the deaths were again, So I think this is all in favor of the study arm. Next slide. So like you saw with olaparib, so here you see olaparib and bevacizumab giving you a hazard ratio of 0.59 and 22 months PFS versus 16.6 months. So this is irrespective of BRCA1, 2 status. This is the intent to treat population here. So when you come to BRCA1, 2 or HRD, the hazard ratio will become more robust, suggesting that the drug works in BRCA1, 2, and in patients with HRD positive status as measured by the genomic instability determined by factors more than 42, those 3 factors. Next slide. So I think you can see here the tumor BRCA mutation. Again, the hazard ratio comes to 0.31, 0.33 for HRD positive. So look at the importance of HRD here. So here is the evidence, as they say, it is the proof of eating, lies in the pudding. Next slide. Okay, so the results of pre-specified PFS subgroup, you can see a majority of the forest plot is showing that patients who were on olaparib and bevacizumab did better than bevacizumab alone. Next slide, please. So I think these are the important concepts, and there is no additional side effect profile than the olaparib alone. So the treatment is fairly well tolerated. Next slide. So this is now coming to, this was the first line maintenance studies. What about in relapse platinum sensitive, high grade cases? Next slide. So you see, these are the patients who had more than 2 prior lines of platinum, and they had CR and PR on most recent therapy, and patients were and they had the germline BRCA1/2 mutation, and patients were given olaparib versus placebo because they were in either CR or PR, and they were stratified as per the length of platinum-free interval. Next slide. So I think again to show that these are fairly well-balanced groups, 196 and 99 cases, and the majority of these patients had 2 or more than 2 lines of prior platinum regimens. Next slide. So again, this is SOLO2 analysis, clearly showing that the hazard ratio is 0.75 and in favor of olaparib. So I think, again, stating that patients who are pre-treated but who have a PR and CR can be used for olaparib. Next slide. So SOLO2, this is again the side effect profile. The dose interruption is quite frequent because of the oral ulcers, fatigue, anemia, and discontinuation rate is to the tune of 11% or 15%. Next slide. So I think this is a slide again to showcase the side effects. Next slide. So this is again to show, this is the phase 2 study, on olaparib maintenance in platinum-sensitive recurrent cancer, and this is irrespective of the BRCA1/2 status. And here the dose was earlier. This was the first trial where 400 milligram twice a day olaparib was given. Next slide. So you can clearly see that these patients, even irrespective of the BRCA1/2 status, they have a hazard ratio of 0.35, and patients who are platinum sensitive. So that becomes a surrogate marker for the use of olaparib. Next slide. So 3rd line and beyond in platinum sensitive or resistant BRCA mutated ovarian cancer. Next slide. So this is the SOLO3 trial where patients with germline BRCA mutation were either, who were responding to platinum chemotherapy were treated either with olaparib or with non-platinum chemotherapy, 178 and 88 cases, and they were platinum sensitive. So that was the inclusion criteria here, and they had germline BRCA mutation. Next slide. So you can see the response rates in favor of olaparib very clearly. Next slide. So So I think there is clear data here that olaparib is the most extensively used PARP inhibitor in the HGSOC, and BRCA testing is at the moment readily available. HRD is available, although costly, but if you combine both, one can get nearly 50% of the patients who could become candidates for PARP inhibitor maintenance, because if you have HRD, then you can give PARP inhibitor and bevacizumab in newly diagnosed cases. If you only have BRCA1 or 2, then one can give only olaparib in the maintenance setting. So HRD status is dynamic and very based on the test ordered. I think frontline maintenance, we've already said. So I think we have understood by and large that olaparib is a drug which is meant not only in the platinum sensitive CR/PR relapse patients and the third line even, but also meant for in the maintenance in front line. So with this, I rest my case. Thank you very much, Sajjan, for inviting, and thanks for patient listening.
Thank you, sir, so much. I think with your talk, the things have become more clear for all the clinicians. I hope that your talk has been really useful to all the delegates who have joined across the country as well as outside the country. And if any of the panelists have or any experts have any questions, the house is open. So if I have one question.
Sure.
Sir, if like we don't have the myriad test with here with us, so what do you do in your clinical practice, especially to try to find those people who could have? Does NGS, a comprehensive NGS, help us, or what do you do in your clinical practice? Because normally most of us are satisfied with just sending a germline mutation for BRCA1 and 2 and decide, okay, that does not come positive. Then many of us actually don't even end up getting somatic mutations in real life, sir. So what do you feel is the takeaway from your...
Sajjan, you see, currently the answer is very, very clear that the HRD test should be performed from Myriad only. I know it is expensive, but the point is that the drug is equally expensive. So, in the first year, then you are going to use 13 months of, the cost is 13 months instead of 12 months. So I think you need to discuss it out because the approval for olaparib is with the companion diagnostic Myriad HRD test, and it should be more than 42. So there is no substitute for Myriad at this point in time. So we had a advisory board recently with the AstraZeneca. So I believe they are working on a cheaper test which may come around from the validation is going on in Europe, I believe in Sweden. Until we have that test, even the foundation test only gives you LOH. So, I showed you very clearly that in the frontline upfront maintenance, that is no substitute for using olaparib along with, bevacizumab. So I think we have to follow the guidelines. And the drug is so expensive. So if somebody can afford 12 months or 24 months of olaparib, I'm sure the family can afford 2.5 lakhs or 3 lakhs or whatever for the Myriad test.
Okay, so I totally agree with you. I think that's a very valid answer at this point in time. Yeah.
Sir,
anybody else? Yeah. Okay.
Sir, in the maintenance setting, that is, for example, the patient has a very good response and then we go for maintenance. Yes, I understand that the myriad test will be essential. But let us say the patient has a evaluable disease and we have a choice to go for myriad, my choice, or versus just using 3 monthly cycles of olaparib. Since it is also approved in non-BRCA mutations as well, or like any other PARP inhibitor for that sake. We have niraparib, which is approved in without respect to the BRCA mutation. So, for example, we use 3 months, so that would almost also cost the same. And after 3 months, and we can evaluate and indirectly if it is responding, it means that it was there, and we get a hit-and trial method.
Yeah. But there is no guideline to do that way, Dr. Muntasir. So the guideline is very clear that in order for us to give the olaparib alone, so BRCA1, 2 tumor, somatic and germline is readily available at a reasonable price. So the issue is HRD for the balance 25. So that hit and trial method is not approved by any guideline as of now.
Yeah, of course, sir. Of course. It is not approved. I was just trying to kind of improvise that if there's a disease and we have a drug, and why, and because it is approved, sir, in, for example, non-BRCA1 and 2 mutations as well. Say the niraparib is approved.
Yeah, so niraparib you can use. So if that does not require the HRD testing, sure, go ahead. If it doesn't require it, I have no objection. So you need to follow the guideline. As regards, I think Dr. Sajjan was asking regarding the other HRR genes. So we don't understand that what is the contribution of those HRR genes in HRD. I mean, Dr. Aparna can take that a little more in detail because I clearly showed you that slide. The contribution to HRD status of the other HRR genes is not clear. Although RAD51C, I showed you that slide, that may be a little more, but then there is no guideline, to do the RAD51 also. I mean, I wish it was there. Then we can say 3 genes, but they haven't validated that. Dr. Aparna, please, you're there. Yeah.
I completely agree with you, Dr. Agarwal. No contradiction. I completely agree with you. And I think that's what even I said, that we do know it has an effect, but we're not really sure if we can treat them. So I agree with you. I know they're part of the same pathway and they have a similar function, but with respect to therapy, I think we still need data. And I think there are some of them like ATM, which really doesn't have, the efficacy is really poor of the drug. PALB2 in ovarian cancers actually have a poor efficacy to your PARP inhibitors. So we slow and steady, we are getting there at this moment. But yeah, I completely agree with Dr.
Thank you so much for such important discussion on these topics, and I think Dr. Mudassir also has brought in that topic of being Indian. Like we have always had that jugaad in our mind.
Basically, Dr. Mudassir's heart goes out to patients, and he wants to give the benefit of the drug to maximum number of patients. You can't, go around the guidelines, please.
Yeah.
Correct. Agree.
Thank you so much, sir. Thank you.
Sir, just one point.
One more question.
Sir, actually, this was not my idea. Actually, when I explained the same thing to a patient, and the patient said that why not take just 3 cycles of drug and,
Yeah, the problem is, Dr. Mudassir, that you give the drug and the patient has some unacceptable side effects. Well, then the onus is on you, that why did you write it? And why the problem is that. So you cannot just go around the guidelines.
Agreed, sir. Agreed completely.
So thank you, everybody. And now we switch gears and we go to the role of PARP inhibition in breast cancer. And for that, I have my very dear colleague and friend, Dr. Rajat Bajaj, who is a senior consultant at Fortis Noida Hospital. And he'll be enlightening this topic. And over to you, Dr. Bajaj.
Thank you, sir. Thank you. I hope my slides are visible. Am I audible?
You're visible and audible.
Okay. Thank you. Thank you for having me here, sir. And after this very nice talk by Dr. Shyam Agarwal, sir, my job is to talk about the role of PARP inhibitors in metastatic breast cancer. In the next 15 minutes, we'll be talking about what is the local scenario and the unmet need in breast cancer. What are the treatment guidelines as far as the conventional treatment is concerned? Where do we really fit in the PARP inhibitors in MBCs now in 2021? And talking about mainly the study which has brought olaparib into the setting of treatment of metastatic breast cancers, which is the Olympiad study. So we do know that the 5-year survival in breast cancers is not very bright. Of course, it has been improving over a period of last 5 to 10 years. But if we talk about triple negative breast cancers, it may be just about 20%. We know that in the Indian population, the triple negative subset is more than what it is for the Western population. And also it is very important to know that 5 to 30% of our patients of breast cancer will harbor a germline BRCA mutation. In Asian patients, this data can go up to 30.8%. That is, it can be a little more than what it is for our Western counterparts. That is why a BRCA mutation is generally an important investigation that we do in our metastatic breast cancer patients if the patient is falling into that ambit. If we talk about the tumor biology and the survival, we do know that we have patients who are either hormone receptor positive or HER2 negative, or for that matter, triple negative breast cancer. The triple negative breast cancer population has not shown much of improvement in terms of survival in the last many years, as is very clear from this Kaplan-Meier curve that is there on the screen. So the unmet medical need in metastatic breast cancer has been there always, which is that we should come up with the therapies which can improve the overall survival in patients of metastatic breast cancer, and if not overall survival, then at least a progression-free survival should be improved. And here the case in point being that if we talk about the median PFS with standard single agent therapies which we have, which are post-taxanes and anthracyclines, they have shown a PFS of about 4 to 6 months only. There are few Indian studies which have shown a median OS of 6 months, especially with eribulin monotherapy. We're talking about the eribulin study here. So olaparib offers a new targeted treatment option for patients who are HER2 negative metastatic breast cancer, along with being germline BRCA mutant. This is what we'll be talking about. So also it is important to understand that many of our MBC patients do not reach the next line of therapy. This is the amalgamation of data that we have over the last 15 to 20 years, where we see that there are many studies which suggest that many patients in MBC may not receive the third line or the fourth line. In fact, the attrition is so high that patients in third line receiving the third line will be just about, say, 50 to 60%, and in fourth line they drop down to, say, about a dismal of 25 to 40%. So it is important to use your best weapons upfront. And also it has been seen, and I'll show that in the Olympiad study also, that when the PARP inhibitors are used in the initial setting, they have got a deeper response or a better survival as compared to if they are used in the further settings. We know about the hormone receptor HER2 negative breast cancer, that there are many endocrine therapies that we have now, and there is a lot of improvement which has happened in the last 10 to 15 years. So has been the case with triple negative breast cancer, with many chemotherapies coming into the picture. These are the ABC guidelines which recommend that in a patient who is an endocrine positive HER2 negative patient, and that patient has to be treated with chemotherapy. Suppose there is a problem of visceral crisis, or if there is a proven endocrine resistance, there is a sequential single agent chemotherapy that we prefer. If the patient is previously untreated, then we resort to either anthracyclines or taxanes, which are the two most active agents in the treatment of breast cancer. Or if it is a previously treated with anthracyclines or taxanes, then we resort to either capecitabine, eribulin, or vinorelbine. If we talk about the treatment of triple negative breast cancer patients, this is the flowchart for the triple negative breast cancer patients, where we see that if the patient is having an advanced triple negative breast cancer, then we generally start these patients on chemotherapy, which can either be sequential or combination. Mostly the combination is preferred only in patients who have got a proven rapid progression, or they are in visceral crisis, or if we have a need to rapidly control the systemic symptoms. If that is not the case, then we resort to single agent sequential therapies, because it has been seen that doublet doesn't really dent the overall survival, and the sequential agents, they do remain the same. Also, we have now started to use the PD-L1 status also upfront in our segregation of such patients in the beginning, with the IM Passion study coming into the picture, and the SP142 is something that we do. And also in this study that I'll talk about, we have a message that we should also do a BRCA mutation. And if the patient is having a BRCA mutation, then we should resort to using a PARP inhibitors. This study showed that the PARP inhibitors should be used in maximum number of patients only once the anthracyclines and the taxane combination has been used. These are the various chemotherapeutic drugs that we have for the treatment of metastatic triple negative breast cancer, and I'm sure my august audience doesn't really need to revise all these medications. We all know that. So coming straight away to BRCA, we do know that BRCA1 and BRCA2 are the tumor suppressor genes, and these are the genes which regulate the cell growth and prevent the abnormal cell division. And how this mutation happens, we all know that. These BRCA mutations in breast cancer, so a little epidemiology, BRCA1 and BRCA2 mutations account for about 20 to 25% of the hereditary breast cancers. women will have certain specific features. If we have to really find which women will have these specific inherited mutations in BRCA1 and BRCA2, these will have an increased risk of both breast and ovarian cancers, along with many other cancers like prostate and pancreas. So if we talk about the relation of BRCA positivity with the disease biology, so most of the BRCA mutant patients are triple negative breast cancers, about 80% of them. Most of them are BRCA1. If we talk about BRCA2 are related more with HER2, hormone receptor positive, HER2 negative. About 20% of BRCA mutants patients are going to be triple negative. So in both of these, that is triple negative as well as hormone receptor positive patients, HER2 negative, there is a need and a possibility that PARP inhibitors can come into the picture, because PARP inhibitors do a world of difference to patients who are having a BRCA mutation. And remember, in breast cancer, we are talking about only germline. We are not talking about somatic at all. We are talking about only germline. So if we talk about the PARP inhibitors, how do they really exploit this particular word that we all know with PARP inhibitors, which is called synthetic lethality? So PARP enzyme is an enzyme which is required to repair the single-stranded DNA breaks in normal cell, and the homologous recombination is required to repair the double-stranded DNA breaks. Dr. Aparna has already spoken about this. So PARP inhibitors, single-stranded breaks are prevented. They lead to an increase in the double-stranded breaks, and already when there is no BRCA, that is their BRCA mutation is there is a deficient homologous recombination pathway in that cell, which leads to apoptosis and cancer cell death. Coming to this trial that we're talking about, this is a phase 3 randomized controlled trial, which is called the Olympiad study. This study was presented in ASCO in 2017 in the plenary session, and later on in the same year was published in NEJM. And this trial had an inclusion criteria of HER2 negative metastatic breast cancer patients. So they could have been triple negative or hormone receptor positive. They had to be all germline BRCA mutant, along with receiving a prior chemotherapy, which was taxanes and anthracyclines. Up to 2 chemotherapy lines was allowed in the metastatic setting. And if the patient was endocrine positive, then this patient had to receive at least 1 line of endocrine therapy. A prior platinum use is something which is important. So if the patient had a prior platinum use, no evidence of progression during that treatment in the advanced setting was needed. And these patients were randomized 2:1 to receive either olaparib in the standard dose or a physician's choice of therapy, which was either capecitabine, eribulin, or vinorelbine, according to the ESMO guidelines, which I just showed you. And primary endpoint was the progression-free survival, with the secondary endpoint being overall survival and the objective response rates. So talking about the baseline characteristics of these patients, it is very important to have a look at the baseline characteristics of these patients. So if you see the hormone receptor positive and the triple negative patients, they were almost like 50% in both the arms. Then the new metastatic breast cancer patients were about 12%, and there were about 75% patients in both the arms who had more than equal to 2 metastatic sites. That means the disease burden was quite high in majority number of patients, and there were about 30% patients who had previous platinum-based therapy for breast cancer to be used, and about 70% of the patients had previous chemotherapy for breast cancer. So which means that about 50% of the patients were triple negative. About 30% of the patients were receiving this treatment as the first-line chemotherapy for MBC, which is very important because we'll have this in the further slides as an important information. About 70% of the patients did not receive platinum therapy initially. Now, if you look at the PFS by the blinded independent central review system, the PFS, which was the primary endpoint, was well met, and hence this was a positive study. If you look at the Kaplan-Meier curves, we see that the Kaplan-Meier curves are separating widely from the very beginning. The progression-free survival was about 7 months in olaparib arm, and was about 4 months in the physician's choice of chemotherapy arm, with a hazard ratio of 0.58 and the p-value being highly significant. If you talk about the overall survival, this data is still not mature. The Kaplan-Meier curves are almost hugging each other. So overall survival, which is the secondary endpoint of this study, is still not met. You see that the numerically it is in the favor of olaparib, 19 versus 17, but the hazard ratio is 0.9 and the p-value is not significant. But very important to note is that if you look at patients who received olaparib as the first line of therapy, that is in the first line of therapy, the p-value for the overall survival in these patients was 0.02, which was significant. That is, the overall survival was 22 months versus 14 months, the p-value being significant. Also, if we talk about the segregation of the data that we have, and dissecting it further on the basis of the tumor biology, the hormone receptor status patients, which are hormone receptor positive patients, they did a shade worse as compared to triple negative breast cancer patients. As is expected, triple negative breast cancer patients had a better PFS, both by BICR and the investigator assessed, and a better PFS2 as compared to hormone receptor positive patients. And if we talk about the 7-month PFS which we have with olaparib, of course this is a cross trial comparison, but if we compare it with the platinum based therapy which was compared in the TNT trial in patients who were BRCA mutant, that there also exactly similar PFS about 7 months was seen. Very important to note, like I said in the beginning, that the platinum compounds were not given in the physician's choice of therapy. So it was not compared with platinum. That is why we can't really say in this trial, but the TNT trial data we do have. And if you talk about the other endpoints that we had, that is the PFS, the time to further chemotherapy, all this was significantly better in the olaparib arm as compared to the physician's choice arm. Hence, olaparib had the potential to prolong the chemotherapy-free interval as well. And with this benefit being maintained even after the subsequent treatment is something which is important. Very important to address is the issues of adverse events. So these adverse events, if you talk about PARP inhibitors, we do know that it causes anemia, fatigue, which was more with PARP inhibitor arm as compared to chemotherapy. But important to note that the adverse events leading to drug discontinuation were in fact more in the chemotherapy arm as compared to the olaparib arm. These are the adverse events, and these are the adverse events of PARP inhibitors or olaparib that we all know by now. They were little more in the PARP inhibitors arm as compared to physician's choice of therapy, which is expected, but nothing very alarming. Very basic percentage of cases which had a grade 3 or grade 4 adverse events with olaparib, which were easily manageable. Like I said, treatment discontinuations were more with physician's choice of therapy. There were good number of patients which were still ongoing or treatment at the time of data cutoff, and they were tolerating the chemotherapy well. When I talk about the tolerance, this is the quality of life data which was assessed. And if you talk about the quality of life data again suggests that olaparib was helpful in delaying the chemotherapy and delaying the overall deterioration of quality of life as compared to the physician's choice of therapy. The time to deterioration of quality of life to favored patients treated with olaparib as compared to the physician's choice of therapy. If we talk about the Asian patients in this particular study, so there were 14% of the screened Asian patients here had a germline BRCA mutation. And if we talk about the patient demographics and their characteristics, they were again well balanced between the treatment arms. If we talk about the hormone receptor status, be it the BRCA mutation or be it the prior treatment exposure with platinum, they were all well balanced between the Asian subgroup and the global population. And if you see, the objective response rates in the Asian subgroup were better in the olaparib arm as compared to the overall population arm, with the Asian subgroup being about 64%, whereas it is 60% in the olaparib arm. So if we are talking about the use of olaparib in our subset of patients, we should be rest assured that even in the Asian population, we do have data. There are fewer patients in the Asian subpopulation who require dose modifications as well compared to the overall population, and this is the data that we have. So very important to understand that if we have a patient in 2021 where there is an opportunity to test for BRCA, and we find that the patient is having a metastatic breast cancer and the germline BRCA turns out to be positive, where can we really fit in BRCA inhibitors in the patient's journey for the treatment? So if we talk about this particular scene which is there in front of you, one is that we have to really test for that particular mutation, be it BRCA1 or BRCA2 in germline, and after that, since we are restricting ourselves only to metastatic, so I'm talking about only metastatic, we have to talk about whether it is hormone receptor positive or negative. If the patient is hormone receptor positive, then certainly it makes sense to give endocrine therapy first. Here I would like to really make a point that in these patients who received endocrine therapy in Olympiad study, most of them, they did not receive CDK4/6 inhibitors in the beginning. It was only tamoxifen or aromatase inhibitors. But having said that, even if it is a patient who has an endocrine therapy hormone receptor positive and is supposed to receive CDK4/6 inhibitors, that should be the first go-to therapy. And after that, if the patient is required to be given chemotherapy for some reason, then olaparib can certainly be considered over chemotherapy. If we talk about triple negative breast cancer, then certainly post taxanes and anthracyclines, olaparib should be used over chemotherapy in such patients, because there is data to suggest that earlier use the better. There are better response rates, better depth of response. If we talk about the first line metastatic, there was some data in this trial to suggest that first line metastatic patients can also go in for PARP inhibitors, but that still remains to be seen in the further studies. So overall conclusion of this particular study is that there was a good benefit, about 42% reduction in the risk of disease progression, about 50% reduction in the risk of death, although the overall survival is still not statistically significant. Well-tolerated therapy. The conclusion is that we should give the option of olaparib to these patients. If the patient is having a metastatic breast cancer, especially if it is triple negative, we should test for PD-L1 SP142 according to the IM PASSION study. If not, then we should test for germline BRCA mutation status as early as we can, and try to give benefit of PARP inhibitors to such patients. Two very important points about the Olympiad study. It was seen that the benefit of PARP inhibitors was maintained whether the patient had more than 2 sites of metastasis or less than 2 sites of metastasis. So it doesn't mean that if the volume of disease is high, then PARP inhibitors cannot be used. It is not like that. And the other is that we are always wary of the fact that we are not using chemotherapy and only resorting to oral therapy, because we somehow consider oral therapy to be akin to endocrine therapy. We have to understand that the time taken for the response in this study was about 40 to 45 days, both with chemotherapy as well as with olaparib. So even if the patient is having a poor performance status and symptomatically the patient requires to be benefited early and rapidly, even then PARP inhibitors can be used. So with this, I end my talk. I thank you all for your patient listening, and back to the organizers. Thank you.
Thank you, Rajat. I thank you for such wonderful presentation. And do we have any questions from any of the faculty members? Dr. Shyam, Dr. Vikas, Dr. Chaturbuj. So I have a question. If tomorrow a patient comes to us with metastatic CA breast cancer, who is TNBC, so do you check it upfront, or how do you do it in your clinical practice for this BRCA mutation status, Dr. Rajat?
Yes. So, sir, what I understand is that we should try and look for the germline BRCA mutation in breast cancer as soon as we can. These patients, like in the Olympiad study, there were about 25-30% of patients who were given the olaparib in the first line. As of now, I would not like to use it in the first line before anthracyclines and taxanes, but certainly in the second line, just after the use of these taxanes and anthracyclines, if the patient can afford and is a germline BRCA mutant, over any further chemotherapy.
Yes, Shyam sir, you have a question.
Yeah, Rajat, I think you said you can give the drug in HR positive cases also. Hormone
Yes, sir.
receptor. So are you suggesting that we should do the BRCA 1-2 in such cases?
So, sir, like I said in my summarization, that in this trial, there were patients who were hormone receptor positive as well. And these patients also were given olaparib after one line of use of endocrine therapy at least. Most of these patients had aromatase inhibitors as the first line of therapy. So there is no data as of now to suggest that if the patient is having a hormone receptor positive status post one line, should the patient be given a and I'm talking about germline BRCA mutation status, should a patient be given the randomization between the second line of endocrine therapy or a PARP inhibitor? But if I have to take it into my practice, I will still like to use endocrine therapy in patients who are having no endocrine resistance, there is endocrine sensitivity, and reserve PARP inhibitors for a later date. If there is any evidence of endocrine resistance, then we generally treat these patients as triple negative, and then PARP inhibitors should come in at least in the second line, not beyond that.
No, hold on. So what we are doing currently in practice is that we are giving them CDK4/6 and an AI, and then we are doing the PIK3C testing at some point in time, earlier or later. And so you are telling us that we should do BRCA 1-2 in all these patients, whether they have a family history or not.
No, so the BRCA mutation status has to be checked according to the family history, not in all patients. Because this particular trial did not suggest that it is to be done in all patients. They only suggested that they took patients in which the BRCA mutation was tested according to the guidelines. The guidelines for testing remain the same. And when they tested, they found out that the benefit, the magnitude of benefit was more in triple negative as compared to hormone receptor positive. And these hormone receptor positive patients in this study, were they endocrine resistant or were they endocrine sensitive? There is no elaboration on this particular point on this in this particular trial. So if I have to take it, I will still resort to endocrine therapy in patients who are endocrine sensitive. Only when there is an element of endocrine resistance, we may resort to this therapy in the second line, not in the first line.
Yeah, but you need to perform the test, especially who have family history, to get the BRCA1 positivity.
Certainly, certainly.
Sir, I have one question, if you allow.
Please, go ahead.
Dr. Rajat, as you said that they did not use the platinum, that was strange. They have used, all those patients had actually already received anthracycline plus a taxane, and this was used as a third agent. So it is not clear, why did not they use platinum? Because as we know from the trial, like the TNT, the platinum is better than taxane, especially in the BRCA mutants.
Yes, I agree. So see, we do agree with that TNT data that platinum is better than docetaxel in the TNT study. But I think most of the oncologists present here will agree that even after the TNT data has been available, we've not been using platinum over and above taxanes and anthracyclines in germline mutant metastatic breast cancer patients. So I think the same was the case with this particular trial as well, and they did not use platinum. But then, yes, this remains the criticism of this study, that if we had a comparison or if we had patients who were given a platinum, then we would have, elaborated further on these results. But there is an exploratory analysis from this particular trial which suggests that patients who received prior platinum, they had a lesser PFS with olaparib as compared to patients who did not receive prior platinum.
Agreed. So as Shyam sir said that in all those endocrine receptor positive patients, we will go by our own guidelines, which we already know that we are going to give CDK4/6 inhibitors and maybe the second line endocrine therapy if they are obviously eligible for that, and then only we may consider BRCA also if by virtue of family history they have been tested and then they have come out to be positive.
Certainly. So according to me, the conclusion of this study is that we should not really be tinkering with our standard of care for the hormone receptor positive HER2 negative patients, but for triple negative patients, since we all are, after the IM Passion study, doing our PDL1 by SP142, we should include our BRCA mutation also into that particular ambit of investigations if the case is, and if the patient comes out to be mutation positive, germline mutation positive, we should include the olaparib as one of our armamentarium options in the second line or beyond, preferably in the second line.
Agreed.
Thank you so much, Dr. Rajat, for answering all these questions, and you had a very good presentation, and I think all of us have really benefited from this presentation, and I hope that we'll have a trial where we'll have platinums, and I think that will really add more benefit to the use of these drugs in breast also. So with that, thank you so much again, and now we move on to the next presentation, and we have our very own Dr. Vikas, who is now ruling Kanpur, and he's sporting a new look. Dr. Mudassar, I see you is smiling a lot. So what is the reason behind this look, Dr. Vikas? This is the effect of Kanpur's water, or you're now having a new sporty look now?
So it's just that I'm in the middle of the OPD right now.
Okay.
There are patients waiting outside. That's why I'm scratching my hair. And definitely Dr. Rajat Bajaj's presentation was that much enlightening that jhatka laga, shock laga. Especially after that hormone positive patients, we start doing BRCA testing, and with more and more options coming right now, it is difficult what to do and what not to do every second. And that's why we have these beautiful conferences and beautiful academic platforms where we discuss, and with great leaders of across the country. I feel much more enlightened at the end of the conference, because it gives us a huge plethora of options to discuss with the patients every time. We have seen a paradigm shift over the last few years as how we manage our patients, and at every point of time with these conferences, we learn a lot, and we had to discuss a lot more, and we can make our patients more confused.
Yeah, thank you. And so before we go ahead, I'd also like to invite our esteemed panelists. So the panelists for today are Dr. Rajit Chanana, Dr. Chaturbuj, Dr. Bipnesh Sansar, and our very own Dr. Mudassar Ahmed. So over to the expert panel and Dr. Vikas.
Thank you, Dr. Sajjan, for a very kind introduction. May I just confirm Dr. Rajit, Dr. Chaturbuj, Dr. Vinod, Dr. Kaushal, Dr. Amit, and Dr. Mudassir. All of them are there, or we are missing someone?
So we are missing Dr. Vinod and Dr. One more doctor there.
Kaushal?
Dr. Kaushal, yes. So rest, the 4 panelists are there. So we have Dr. Chaturbuj, Dr. Bipnesh, Dr. Mudassar, and
wonderful.
Yeah.
So welcome all, and we will keep this discussion very short, but then definitely it involves a lot of discussion. I would be asking in a series of questions in a sequence. Dr. Rajit, Dr. Chaturbuj, Dr. Amit, and Dr. Mudassir will answer the questions as per their convenience. The first case which I would be discussing with this multidisciplinary breast BRCA testing to be done in an ovarian cancer. We have the first case where a 44-year-old lady with an upfront total abdominal hysterectomy and secondary oophorectomy done. She has a very strong family history of breast cancer in the sister, in the father having a prostate cancer, and paternal grandmother having breast cancer. Pathology was a stage 2C high-grade serous ovarian cancer, and the germline BRCA testing which was done was negative for it. So with a strong family history and a germline BRCA testing being negative, would any of my panelists would be having an interest to do a somatic BRCA testing for this patient. Dr. Rajit?
Yeah, hi, Vikas. So I would be do somatic testing only once the germline test is negative. Then I'll go with somatic testing. So ideally, yes, we should do both germline and somatic testing upfront. But what I routinely do is I do germline testing. If that is negative, then I do somatic testing.
Wonderful, sir. Dr. Chatterjee, sir?
So I think, sir, Dr. Vikas, routinely what I also follow the same thing. We do germline first, followed by somatic. But one point what I wanted to highlight is we are getting less somatic test positive because we are following this sequence. If we start doing more, so let's say 3 years before when we were doing very less BRCA testing, we had very less incidence of BRCA positive. But now I'm very much sure that we had much more BRCA positive individual as before we thought. So I think if we do more somatic test, the data will change in the coming 3 years. But of course, there are certain barriers like cost issues, turnaround time. So all those issues are there. But if we do more somatic test, more cases we can pick up.
Wonderful, sir. Dr. Amit, sir, what is your preference? Dr. Amit? We have Dr. Mudassir, sir?
Yeah. I think I agree with though sometimes I have now seen these discussions happening for last I think 1 or 2 years after the availability of the olaparib and the trial results, and we have always started sometimes the mood of the panel is towards the tumor testing. Let us not say somatic testing, but tumor testing first, and followed by the germline testing. And sometimes the mood of the panel is like first the germline testing, and then as Dr. Aparna said that hitting both both with one stone only. So I think ultimately we have to do both. So that is the principle. Ultimately we have to do both. But if the germline is positive, we may not need to do the somatic. But if we do somatic, but then we definitely need to do the germline as well. Because we need to establish that whether it is germline or not, because that may have consequences for the family and the rest of the genetic counseling. And one more important thing is that we have to ensure that the MPLA has been done or not in the BRCA which has been ordered. Because that may not the usual BRCA the test may not pick up the large. Large mutations, large I mean say the genetic changes. What are those called as?
Wonderful. We do have Dr. Vipinesh with us as a panel member, as an addition.
Good evening.
And we also want to know his opinion that as the testing has changed a paradigm shift right now. So does he prefer the germline followed by somatic or the tumor, or he prefers the vice versa, that is tumor and followed by germline testing, or he prefers the tumor first only for the patients?
Actually, in my government sector practice, it's difficult to convince patient for 2 tests. So in case we first do somatic tumor testing and BRCA is positive, then we can counsel them for arranging the cost for therapy. So I'd like to first test them for somatic mutation, which is a little bit likely more chance of detecting a BRCA mutation. Otherwise, I agree with other panelists.
So tomorrow, the Astra offers everybody a free coupon for tumor BRCA testing for all the patients. So just aside the cost issues. Now we have. What do you think is the challenge for you to prescribe a tumor BRCA testing, Dr. Rajit sir?
So the challenge in mostly in panel patients, so they already are their treatment is already delayed due to various permission issues. So I don't want them to waste their time with BRCA testing. So I would rather start them on treatment and then offer BRCA testing. And for other TP and the other patients, I would like to start the treatment first, and maybe later on I can counsel them for BRCA testing. So because the patient is already very anxious regarding the start of treatment, so their priority is starting treatment first. So that's my answer.
So you are worried about the turnaround time in terms of the logistics and other reasons for it.
Yeah, so I am worried about the panel patient getting treatment delayed and the other patients getting treatment somewhere else.
So, Dr. Chaturvedi sir, do you also agree with the same, or what are your challenges for not opting for a tumor breaker testing upfront for these patients?
So I think A and C, I would go with these two options because these are the two major challenges. I am confident about tumor BRCA testing. We have now scientific evidence. We already had a lot of discussion on tumor BRCA testing. Test cost, I think it is coming down now. It's not that difficult. We all are fortunate that we are looking, patients that who can afford, because if the patient cannot afford test cost itself, then the further therapy will definitely be out of question. Test quality is of not that much concern, but yes, definitely access is a very much concern, and very few labs they offer tumor BRCA testing. Even most of the labs they are not aware also. So these are the two challenges which I pose. But I agree with Dr. Rajit that we never wait for these reports to come and then we will start the treatment. We always start the treatment and then we may later on modify depending upon the tumor BRCA testing reports.
Wonderful. Dr. Mudassir, sir, do you also, what do you feel as a challenge for not opting for a tumor breaker testing upfront?
Okay, for the tumor BRCA, I think one is the test cost is probably not the issue now. I think all of the companies are getting, giving us coupons now. So it has become quite cheap now, I think. And sometimes you can do it for free. Even the HRD, you can do it for free. I think HRD, the type of HRD, whatever they give us, not the myriad my choice. And then very few labs are offering. Yes, that is one challenge. But the timing is not the challenge, because anyways we won't be changing our decisions based on the BRCA or HRD testing as of now. We will be actually only deciding about whether to go for maintenance therapy or and which type of maintenance therapy, if at all, we have to decide. And the rest of the genetic counseling, etc.
So, Dr. Vipnesh, again, I ask you the same question, that tomorrow Astra is offering you a free coupon for a tumor breaker testing for all. Would you do it, or you would have still some reservations out of the above mentioned options?
No, apart from test, if it's available easily, then there's no reservation about doing it.
Wonderful.
I'll go for it.
So, do you believe that there is a difference in clinical outcomes in response to whether testing is done on blood, or whether it is whether the breaker testing comes in terms of positivity in tumor samples? So, Dr. Rajit, do you think there is a difference, or do you believe that the germline breaker and the somatic breaker testing, they are similar?
So I'm sorry, I missed your question. I have to attend one call. Can you repeat your question?
So the patient has a germline breaker positivity, and the patient has a somatic or the tumor sample positivity of the breaker. Do you think there's a clinically difference in the outcome as to the PARP inhibitors response? When
No, I don't think so that there is a difference in the response.
Wonderful. And any of my panelists would like to differ that is there a difference in the response rates with germline breaker testing or the somatic breaker testing? We have 3 trials right now. All of them have shown that there's a similar efficacy with either of the drugs like olaparib, niraparib, rucaparib. Whether the breaker test comes out to be positive in germline or in the same.
Actually, so, Dr. Talreja, if you just turn the previous slide, it is evident from your slide that what is the difference between these two columns is actually the number of patients. See, most of these patients had a germline BRCA mutation. So we have good data available for that. But can we just compare, because the subgroup analysis, can we compare it? Though it shows definitely, as you have shown, that HRs are like 0.23, 0.27, 0.23. Yeah, certainly I believe it, but I think it was a subgroup analysis, if I'm not sure.
I totally agree with it. That's why I put up the question, sir, that do you believe that the germline and the somatic are similar, or you have a difference of opinion? No, I believe that somatic is greater or the germline is greater in terms of the response rate that you are going to prescribe. You see a BRCA report, do you look at it whether it's a germline or it's a somatic, or you say that no, it's a BRCA positivity, I will give the PARP inhibitors irrespective of whatever?
I will give the benefit of that BRCA mutation and the PARP inhibitor to that patient, whether the patient has germline or somatic. The somatic will come to know only after when you have done both the tests, and then it is only positive in probably tumor and not positive in the blood, and then only. Most of the times we are talking about the tumor BRCA rather than the somatic BRCA.
Wonderful. So we tend to know that every panelist does tend to agree that germline BRCA testing alone is not sufficient, because nearly 21% of pathogenic mutations we are tend to miss if we test only the germline, and that's why a sequential testing is to be known. And when we advise a BRCA testing, we open a plethora box, as you could see that the more we are afraid of that BRCA report to be coming out, because we find these numerous terms associated with it, whether it's a BRCA wild type, it's a BRCA VUS type, it's a BRCA mutant type. What's the IRC classification for it? It's a class 1, 2, 3, 4, pathogenic, non-pathogenic, definitely pathogenic. That's the good, bad, and the VUS of it. So again, to Dr. Rajit, first, these three questions, that when it comes as a VUS in ovarian cancer, do you go and see the breast data for it? How do you imply the patient for a family genetic counseling in case of VUS? And do you refer, when there is a report of VUS, to a genetic counselor to get it, the opinion done for the same?
Yeah, so VUS, as the name suggests, the significance is unknown. So I don't advise the patient any familial counseling or genetic counseling, because till the time we don't know it, there is no point in scaring the family. So, but we need to collect the data. Maybe later on we can get something. But as of now, I don't think there is any implication of VUS.
Dr. Chaturvedi, you would like to agree or you would like to differ in this?
So no, I agree, totally agree, because the VUS is one category which requires. So there are I would like to elaborate. There are three counseling sessions. One is pre-test counseling, then breaking the result, and third thing is post-test counseling. Once you have a VUS report, the post-test counseling becomes so much difficult, because there are a lot of gray zones. The patient keep on asking that whether this mutation is important. You keep on telling no, it is not pathogenic, but yes, it is also not non-pathogenic. So a lot of so whenever I saw VUS report, I landed myself in. I'm still in that practice learning mode of how to break out and explain a VUS report. Number one. Number two, when you have a VUS report, somebody can correct me if I am wrong. You need to check the library constantly, and how frequently we should be checking it, that I am not aware, because at some point of time that VUS may become significant. And third thing, what about the first degree relatives of a VUS patient? Should they be subjected to BRCA mutation testing? So that is again an area of gray zone. Once you have a VUS report, are you really justified in telling the first degree relatives to get the BRCA testing done? So that is again. So these are the three challenges which I face.
I'm very, very sorry to break the chain right now, but I can't resist then invite Dr. Aparna that she can be gracious enough to enlighten us with this VUS, because a VUS of one lab, does it mean that the VUS of another lab, or is it that that once a VUS, because every time as we read that it should be definitely updated in the Clinome or whatever the universal data is, and it should be looked up to. And always we find it difficult that a VUS of ovarian, does it mean that it's a VUS of prostate also, or it might be a pathogenic in breast cancer? So Dr. Aparna, please enlighten us with this VUS.
VUS is, I agree with you, is possibly one of the, we don't enjoy those in our post-test counseling either, especially when there's a strong family history or there's therapy involved. So to answer your question, if there is a VUS upfront, irrespective of the cancer type, a VUS is a VUS. It's not something that a lab just comes out with and says that, I don't know what this is, so I'm going to call it a VUS. We do have softwares and algorithms in place. That's the first checkpoint that looks at these variants that differ from the reference genome. This is how we call out variants. And on those mutation taster, for example, which is germline, which we use for germline testing, that actually looks at it and says, okay, this is a particular spore, it looks like a VUS. Then we look at a variety of databases, ClinVar being the most common one that's used in germline, and we go back and we look at data and we see, is this a true VUS? And then it gets called out as a VUS. So a VUS at Core Diagnostics, a VUS at Myriad or Ambry is all the same. It doesn't change because we are not aware or they're not aware or because of population genetics or whatever. I think today we're in a much, much more better position than we were a couple of years ago, at least a decade ago. There is sharing of data. We do have access to everyone's databases. So, you know, we can call out a true VUS. Now, how do you counsel this? It's a little tricky. How do you counsel a patient? So what I've learned is that in the pre-test counseling, we kind of preempt this, especially now as we're going into these, HRR testing, and we're going into these expanded germline testing. We do go ahead and we do kind of tell our patient that, look, there is a possibility on an HRR, an extended germline panel, that there's a 10% possibility you are going to get a VUS. And this is what's going to happen. And again, with VUSs, how do we deal with them in our clinics? They're very, very different. If you have an extremely strong family history, a very high risk family, which means more than 3 first-degree relatives who've been those typical red flags that you have, there is the option of something called co-segregation studies that can be done to see, is this VUS a true VUS or can we reclassify it? And then we understand how to deal with them with respect to management and surveillance. The way we talk to them is very different. If this is a moderate or a low risk family, then you have, it's a conundrum that we all land in, that what do we do with this VUS? Like, is it actionable? Is it not? So one thing that we've learned, and especially in the cases of where we've got very stressed out, anxious patients, step 1, no prophylactic surgery, no risk reducing surgeries, no therapy can be recommended on a VUS. That's a blanket. No matter what anybody tells you that this BRCA1 was found in the exon 10, which is the hotspot for BRCA1. If it's a VUS, it's a VUS. You have a medical legal issue on your hands if you treat a patient based on a VUS or you do any sort of risk reducing surgeries. 2 is that what we can recommend in high risk cases is maybe basic management and surveillance that really that's not very stressful to a patient. So a patient still has a sense of reassurance that, yeah, I can go back and do something to reduce chances for my family. And from a lab perspective, what we do in our cancer genetics clinic is every 6 months, we reassess these VUSs. And especially in cases where I do have a doubt, we do go out checking with, so we have partnered with Ambry. So that's where I tend to go, and I worked with them in the past. So I tend to go back to them and just request them that, is this a VUS? Is there any sign of this going to, be a pathogenic? Do you see it being reclassified? So we get that kind of information about that mutation. So I think that's why a genetic counselor, having somebody on board, is extremely important. If you want to counsel your patient, that's fine, but do check with us just once so we can give you some more information about your variant. So I hope I've answered your questions.
And Dr. Aparna, on a lighter note, you can also use Dr. Chatubu's library. Now he has opened a library for VUS, as you can see now. So whenever you want to check, Dr. Chatubu has opened a virtual library for you.
Sir, it's not library. Basically, it's basically last time when I got a VUS patient, so we told her that after 1 year, maybe this VUS may become significant. So after 1 year, she came to me and she asked, now doctor, tell me. And I didn't have any answer because I didn't have any update about that. Second question, which I just wanted to ask, that whether we are justified in getting whether we are justified in getting the BRCA testing done for the first degree relatives of VUS patient, because when we have a pathogenic mutation, we are very clear.
It's a very good question. So in the case of high risk, very, very rare cases, especially in a high risk family, where we do have multiple relatives, like first-degree relatives who are getting breast cancer, triple-negative breast cancer, ovarian cancer, pancreatic, male breast cancer, and I'm just sticking to HBOC right now. So anybody under the age of 50 and immediate first-degree relatives, and we are seeing like 3-4 of them under the age of 50, very young, some having multiple primaries. In cases like that, what we can do is those who have been affected, if they are alive, we can go ahead and look for what we call co-segregation studies, which is where we go in and we analyze the as to how is this going to be reclassified as being a pathogenic mutation. It's a pretty extensive study. It takes around 3 to 4 months to get results, but that is one option that we can look into, because labs are not doing it. This is from a research perspective. The only lab that I know that does this is Professor Rajiv Sarin's lab at Tata Memorial. I know he does it. So if I see a family that is suspicious of this, and it's extremely, a really, really high risk family where in any of our risk prediction scores, as much as I don't like using it for the Indian population because that's done on Caucasian data, anything above 65-70%, I know it's high risk. In cases like that, I may consider sending it over there for co-segregation, but otherwise, no, I would not recommend VUS cascade screening testing for anybody. What I would recommend is don't do the testing if they have the fear because it's, male breast cancer or something like that in the family, maybe management and surveillance, but just having the entire family dealing with a VUS report and going that, I don't know what to do with this, and everyone sitting in perpetual fear that, just the slightest ache or pain somewhere and people just assume it's some sort of cancer that is starting. So cases like that, I don't recommend. So I also get your patient that came back after a year. Some of our patients call us every week, change ho gaya, classify ho gaya. So I kind of, VUSs are not fun, but pre-test, briefing them, giving them a heads up in pre-test, I have seen it kind of reduces the blow in when that VUS comes in post-test counseling.
Very well said. And I wouldn't ask this question to anybody because I believe that all patients should be sent for genetic counseling. So the question that I would definitely ask, because since I am Kanpur, it is difficult to send a patient to Dr. Aparna in Delhi for a genetic counseling.
Virtually, telegenetics. We're in 2021. All our patients are virtual. Even my Delhi patients are virtual.
So what restricts my Delhi counterparts to send their patients for a genetic counseling session with Dr. Aparna? Dr. Rajit sir?
So I think availability of genetic counselor. So that is the issue because we don't have an in-house genetic counselor. So we already outsource some of the tests. So as I said that my priority is getting the patient first started on treatment. Later on, yes, I definitely send the patient to a genetic counselor.
Dr. Chaturput, your?
So I think we are privileged that so we have a full-time genetic counselor available with us. So I think availability is not the issue in our institute. But yes, quality of genetic counseling, that does matter because I told you that there are definite 3 tiers: a pre-test counseling, breaking a report, and a post-test counseling. And somebody, we means not everybody is as refined as Dr. Aparna. So somewhere people are lacking in the counseling. Waiting period is definitely it depends upon how much time you give for counseling. So when you have 3 patients in a row, you can shorten your counseling time. That is possible in India.
So waiting period for your also, because the patient will first see you and then you refer the genetic counseling.
Yeah.
Yes. So the waiting period is more for Dr. Chaturput, I believe. Dr. Mudassir sir, your reply?
I think the availability of genetic counselor, we don't have an in-house genetic counselor, and what I usually do is wherever I have done the BRCA testing from, I ask that lab to coordinate a genetic counseling for the patient, and they usually do it most of the time. And the most important thing is the genetic counseling will not stop my treatment because it is not a kind of a prerequisite for my treatment. So I can go on with my treatment, and I can at the same time inform the patients and the family that they should be taking appointments for the genetic counseling.
And Dr. Vivek, sir?
Yeah, same. That availability of genetic counselor is a big problem for everyone. And because as we just shown the multitude of possibilities that can happen with the VS and all, so it's difficult to consult the patient by yourself, and so that's a big problem.
So I believe Dr. Aparna should organize more virtual sessions. I believe all should have a more physical clones of her, so that every center does have one Dr. Aparna Dhar for the genetic counseling to be done to match the standards of the standards she has set upon for the genetic counseling. We move now to the case 2. Simple case, 50-year female, high CA with a significant history of breast cancer. Now on workup has a ovarian cancer, stage 4B, germline BRCA positive, and was just given 3 cycles, chemo, good response, surgery, more chemo. Now what? So Dr. Rajit, these are the 3 options that you have. First line maintenance, you would like to give her olaparib, you would like to give her niraparib for 3 years. Suppose tomorrow NATCO comes again with its notorious a drug available, or the any other company comes up with niraparib for 3 years. So your choice for it.
So I'll explain the patient regarding all the options and all the benefit. If the patient is affording, then I'll go with olaparib maintenance.
Dr. Chaturbuj, would you also agree with the same, or you have a difference of opinion right now?
No, I think I would be more comfortable with olaparib, but I like the way you said Netco with notorious niraparib. There are a lot of N in it and a big no to it.
So that's why I hope Netco is not in the sponsored list right now, and we are not anticipating any of the olaparib Netco versions in future. So definitely, as my esteemed panelists have told, that yes, there is a difference in the endpoints with the PFS, with a significant hazard ratio of 70% reduced risk of progression when you give olaparib maintenance in the first line situation, and definitely in the post-hoc analysis also, those who have achieved a complete response, they have a better response rate, and first line. That's why olaparib got its regulatory approval for the same in the same. So if the patient is at high risk of recurrence, how do you define those who have a high risk of recurrence, as these are the patients who are going to benefit more as compared to those especially with such high cost constraints in there. Dr. Modase, what do you think are those patients who do you think has a high risk of recurrence as compared to those who have a low risk of recurrence?
Okay, we are talking about now only of stage 3s and 4s, isn't it?
Yes, sir.
So for stage, I agree with this, that the patients who have had a debulking surgery and have no residual disease, and they have done an upfront cytoreductive surgery, I think definitely they are the best. I mean, say the lowest risk patients, and all other patients would actually mean a higher risk patients. This is very really important. You know, at the time of telling the patient whether they should be spending that much of money on the on such a prolonged and therapy, and which may have some side effects, some intended and some not unintended side effects.
So definitely that's why Dr. Mudassir has categorically said that yes, there is a difference in the magnitude of the outcomes and differences, but yes, the magnitude is still favoring towards the olaparib, even if the higher risk is those who have a stage 4 or a stage 3 with a residual disease, with an inoperable stage 3, or a stage 3 with an interval surgery. So the patient was started on olaparib based maintenance, and based on your personal profile, how do you think this is? Do you manage the patients with olaparib? Dr. Rajit, how frequently you call them, and what are the most common side effects do you see with olaparib maintenance? Dr. Rajit? I suppose we have lost the connection. Dr. Chaturbuj, can you answer these 4 questions? That what's your protocol for hematological adverse events? What's the dose reduction strategy that you follow? What's the starting dose for olaparib?
So I would like to start with question number 3. So what is the starting dose? So we usually start with 300 BD. This is what we usually start with. Then what is the protocol for management of hematological adverse events? So at least for initial 6 months, we follow the patients every monthly with a CBC report. So we had 2 patients who had isolated anemia developing while on olaparib. So when patient had anemia, there are several reasons, because patient is on polypharmacy, there could be some bleeding. So means we can't strictly attribute it to olaparib, because overall the incidence is very less. So we have investigated the patient for other causes of anemia, but once we didn't find any, so we did transfusions and we waited. But in one patient, it required a dose reduction. So first initial dose reduction is, I think, 50 by 50 mg, so 250 mg we have to give BD. And if the patient tolerates it well, if there is no further anemia, then we can continue. So this is how we follow. But yes, there is indeed a risk of MDS, and we have to be very cautious. If there is no improvement in hemoglobin, then we may need to do a bone marrow. We didn't require any patient's bone marrow till date.
And Dr. Mudassir, what's your protocol for starting dose, and how frequently do you follow, and how do you dose reduce yourself?
So what I usually do is that for the first 1 or 2 months, I tell them to follow up very closely. Let us say about every 2 weeks for the first 2 months, and then they can go on and if they are living away, I tell them to just follow up with the reports. Now we have WhatsApp, so I usually get those reports and then tell them accordingly. Because I had some bad experience with this. I had a patient who actually went away. She was living in Uttarakhand and she continued it, and she did not, follow up for some last year. That was last year during the COVID. And then all of a sudden, I get a call from them, and they said that she has been admitted in some hospital with very severe anemia. She needed blood transfusions, and she had very low counts. So I think it's really important to insist, on a very close follow-up initially. And if you feel that the patient is tolerating it very well, usually that will not, the toxicities may not, occur after that if the patient has already tolerated it well for the first few months.
Very well said, sir. Dr. Bipnesh, do you also follow the same protocol, or do you like to differ, that you also start with 300 milligram BD, reduce it to 250 milligram BD, and you follow up every 15 days or a month for the patient?
Yeah, same protocol, but every monthly follow-up. And I would like to assess the patient properly for any chemotherapy-induced anemia or any other causes of anemia, because anemia is quite common in our country and in the lower socioeconomic strata. So I'd like to have a work up them properly for other causes of anemia before starting olaparib.
Wonderful. And that's how you manage these patients. Most of these events do occur within the first 3 cycles, and you tend to manage them symptomatically, do the drug interruptions, dose reductions as per the protocols. And we now rapidly approach to the 3rd patient. Since we are lacking now time, I would just like a very rapid response from this, that a patient with a triple negative breast cancer, ERPR HER2 negative, Ki67 70%, lymph node positive, staging PET-CT negative, no distant metastasis. Mother had a history of breast cancer. Maternal grandmother also has a very significant history of breast cancers. Should she be tested for BRCA testing? If yes, when, now or later? Dr. Chaturbuj, sir?
So what are the breast? So can you go to the previous slide, please? I just missed the previous slide. So presented with the right breast mass, she was a triple negative breast cancer, lymph node positive. So what is the question?
So she has a all recipe for a BRCA thing to be positive. She is triple negative, a strong family history. When do you think you will be advising a BRCA test for her? She hasn't undergone a surgery. She hasn't undergone any of the breast cancer directed therapy right now. Would you wait for it, or you would say that no, that's the first thing I would like to do for the same patients?
So first thing what we do, we start such patients on neoadjuvant therapy and we immediately send for the BRCA test. Once we send for the BRCA test, we have initial 2 months when we are giving anthracycline and cyclophosphamide. So in the initial months, BRCA test can come positive, and if it comes positive, I will be keen in adding platinum to the taxane in my neoadjuvant regimen itself. So yes, the answer is definitely at the time of diagnosis itself.
Dr. Mudassir, you would also agree with the same, or you would say no, I will reserve when she becomes a metastatic?
No, I think she is satisfying at least 2 criteria for the upfront testing for BRCA. She is young, 32-year-old, and she has a family history too. Even if she was only 32-year-old, she had no family history, she should have been tested anyways. And if obviously somebody is having a family history of breast cancer, that makes kind of 2 points in her favor. And she actually has another criteria also, that she is a younger patient and she has TNBC.
Definitely, yes. And Dr. Bipnesh, do you also believe that it's the right time to test, or you want to test it later?
No, it's the right time to test. I'll not wait. I'll start the treatment and I'll send the testing also.
Oh, very well said answer. So definitely, as we see that BRCA testing is it is quite common, specifically in a triple negative subset with a family history of breast cancer, and she turned out to be BRCA positive, and there is a difference in the outcomes, as you see, with whether she has a BRCA testing done or not. And that's why this question came into the purview that, is my management going to change with the addition of the BRCA testing report there? Dr. Chaturbuj has said that he will be adding platinums to the patient. Dr. Mudassir, would you be adding the platinums to it, or you would say no, I believe anthracyclines and taxanes are the way to go?
The platinum has been shown to increase the PCR rates, but we are not sure whether it increases the ultimate outcomes. But if I feel that most of the times what I do is, if I feel that the patient can tolerate, because most of the problems happens is, tolerability when we add platinum to the taxane. So if I feel that patient can tolerate it and I may use it, for some doses, then I go on. But otherwise, I kind of, after a few doses, stop it.
Very well said. Dr. Bipnesh, do you also agree with Dr. Chaturbuj and Dr. Mudassir's opinion that they would like to add platinum depending upon the tolerance in terms of the BRCA, irrespective of right now the overall survival? Or you would say, no, I would be on a safer side, I will wait?
No, I'll be on the safer side. I don't think there's sufficient data to add platinum, so I'll just go with the standard regimens.
And now comes the burning question: where would you place PARP inhibitors in her therapeutic armamentarium? Dr. Chaturbuj?
So I think now we have Olympiad, so we would definitely give chemotherapy, then we look for the surgery. Now there is a residual disease. So I think you are asking that question. Now, where should I add? So whether I should give olaparib or whether I should give capecitabine. So I think I would give capecitabine. I would finish the capecitabine and then I would put her on maintenance olaparib if cost is no constraint.
Very well said. Dr. Mudassir, you would also agree with the same, or you would say that no, I would wait further more data, let the OS data came, and then I'll take it one.
Dr. Chaturbuj, you are saying that in the adjuvant setting you will be using olaparib?
So if there is a residual disease, I would, on the basis of pre-tax, we need to give capecitabine. But with the availability of Olympiad, I think we can give with the availability of Olympiad, we can give olaparib for the maintenance in adjuvant setting also. If the patient is BRCA positive.
Did they use maintenance? Did they use maintenance?
That was the study designed for an Olympiad, where the HER2 negative metastatic breast cancer was.
Metastatic. We are not talking about the adjuvant setting here.
Yes.
So in metastatic, I definitely would use it. I definitely would kind of reserve it in the setting where it has been given by the trial. That means after the failure of at least 2 lines of treatments. And the only problem with this trial was that they did not use platinum in kind of almost 3 lines of treatment. Let us say they have used already anthracycline, taxane, and now have used one of these 3 options, that is capecitabine, eribulin, or vinorelbine, and they have not used platinum in 3 lines. So that was my only issue. But other than that, I would try to use this, trial. Correct.
Wonderful. Dr. Bipnesh, do you also agree with the same, that you would like to give her a capecitabine maintenance, and in case of metastasis, you would prefer the Olympia study like olaparib monotherapy as compared to?
Yeah.
Perfect.
Nothing to add.
As we see,
what I was telling is Olympia trial, which has shown a 2-year recurrence-free interval, means 84% versus 70%, 77% with or without olaparib. So what I was talking of is Olympia study, adjuvant olaparib, which has recently came up.
Olympia, okay.
Olympia. So I was talking of that study. So based upon that, I thought we will first finish off with capecitabine, and then we will give olaparib.
So I'm not aware of that yet. So maybe.
So definitely a key learning point. And as I finish my talk right now, we have to conclude in paucity of time that managing a woman with BRCA mutation positive is definitely a challenging task, as we see, and we need to use the platinums in this age group, but still it's controversial, depends upon the tolerance. The presence of BRCA mutation does not confer a worse prognostic outcomes, and BRCA is now an established biomarker that has identified who are likely to respond to PARP inhibitors, and use of PARP inhibitors does have an advantage over it. That's why the management of both ovarian and the breast cancer is a multidisciplinary approach. And I thank all my panelists for a very enlightening discussion right now. Thank you, Dr. Rajat Chaturbuj, Dr. Mudassir, Dr. Bipnesh. Thank you, Dr. Sajjan, for giving me the honor of moderating this enlightening session, and over to the organizers for the meeting. A wonderful meeting, I would say.
Thank you, Dr. Vikas. And I know why your hair look like this. They actually make you full of energy. So even after seeing so many patients, you are able to conduct a panel discussion for more than 50 minutes. That's really awesome. And also to all the esteemed panelists for taking so much interest and bringing out all those important aspects which we need to discuss and help our patients achieve their best outcomes. And that has been a really great panel discussion. And the meeting has been really good with respect to learning from each other and bringing that learning to our practice. And with this thing, I'd like to thank all my faculty members. And before I close the meeting, I'd like to just bring in the key takeaways from this meeting, that we now know that PARP inhibitors are an important part of our armamentarium in at least 3 cancer sites. One is ovarian cancer, second is breast cancer, and now also coming in a big way to pancreatic and some of the patients with prostate cancer, which we'll hear in some other meeting. So olaparib remains the preferred choice for us as PARP inhibitor because of the number of trial, number of patients which it has served, and also our comfort with this drug. However, there will be many more new drugs to come, which will further define the further course of treatment in HRD deficient patients. So with this, I'd like to thank the organizers and the sponsors. So sponsors are AstraZeneca and Core Diagnostics for bringing the best minds to brainstorm these topics and get outcomes for our patients. Also, I'd like to thank the organizers for today's evening meeting, DNAMeditech for doing such a wonderful, the whole team of DNAMeditech for doing such a wonderful thing in today's evening. And with this, today, right now, we are at 9 o'clock, and I hope that you enjoy your dinner. And with this, thank you all, the whole team at the organizers, as well as the esteemed faculty members. And till we meet again, goodbye.
Thank you, sir. Thanks on behalf of AstraZeneca to all the esteemed participants for today evening and all the great panel members. It was really insightful and learning session. Thank you, everyone. And just for the benefit of the broader audience, sir, we provide the genetic counseling as part of all the coupons we provide for the testing. So I would request do take the advantage and pass on the benefits to your patients. With this word of thanks, Stay safe, keep safe from AstraZeneca. Good night.
Thank you. Thank you all.